today. How are you?
Good, how are you?
So I do that because I'm getting my Glasgow coma score right now, but if you want to wait down there, that's totally fine. Can you tell me your name and date of birth?
Ashley, 1798.
That matches, so I have the right patient. Today I'm going to do a head-to-toe assessment. So what that's going to look like is I'm going to use my stethoscope and listen. I also can move her down to look at certain places. Nothing should hurt, but if you have any questions during it, let me know, okay?
Okay.
I'm going to provide privacy, so you can pull these curtains shut. You can simulate shutting a door, whatever works for you. I'm just going to look at everything to make sure I don't miss anything because I do it totally different for my own. So when it says verbalize, literally just say it. I am now checking her vital signs, which are blood pressure, pulse, right? Go through all of them. In real life, you would do it, but on this, you've already passed that on. Okay, neurological. So I've done her Glasgow coma score. If I hadn't, I would check the motor, eye, verbal response. So can you smile really big and show me your teeth? Keep your mask down. Good. So while the mask is down, you have a couple options. You can check the nose and the mouth right now. So I'm going to look up and then open your mouth for me. I'm looking for sores, anything that would be a reason why if she's in the hospital not eating. It could just be from a simple sore on the tongue that we're not addressing or something, right? So that's why we check those things. I'm also going to check her pupils, so go ahead and look at my nose. And I'm going to come from the side and just watch it. So come to the side and back out. That is the PERRL, but then there's still an A with the perla, right? The accommodation. You have two different options. The one I like to do is I shine this eye, but I'm actually looking at the other eye. That pupil responds to the light coming in on the other eye, and then do it to the other one. Okay? So that's a complete perla. Next, I'm looking for deficits, so actually, I need to put your mask back up. I didn't appreciate any deficits. Appreciate just means I didn't see. I hear that word a lot. So I didn't appreciate any deficits. If I do see anything, especially with this, because that's stroke concerns, I would investigate a little further. I could have her put both hands up in front. I'm just going to show you a few things after that. Close your eyes. If she is, one's going to go down. It's when they close their eyes, their brain just kind of longer like function and keep it up there usually. Okay, go and relax. So do something to show that you checked for deficits. Next, with my stethoscope, I'm going to listen for rate and rhythm at the apical site, which is where? Yep, at the intercostal midclavicular line. So you have to point or put your stethoscope. I just don't have one, so I'm not going to touch her. Put the stethoscope there and say I would listen for rate and rhythm. Okay. In real life, you do it for the full minute because we're doing a pass off. You can just say what you're doing and then move on. The other option you have is you have to go to the 5 heart sound or spots next. So you could say, find the mid.
Okay.
Top. But I'm going to find that second one. I'm starting aortic, pulmonic, right? And you're saying all the sites. Stop at the mitral because that's where we would end. Say now I'm listening for rate and rhythm. So you see how you can combine it or do it separate. Okay. Next I am. Oh, are you having any chest pain?
No.
Okay. Cap refill. We're checking fingers. So I'm going to do both at the same time, right? Just checking both. I like to wait. You have to do the lower extremities as well, but I like to wait when I'm down at the toes to do it. So you can do both, or you can wait and do it when we get down to the feet in just a minute. Okay? Then next I'm doing pulmonary. So as I'm going to listen to her, I'm going to watch for what effort, and then listen to it again, right? So you're going to say those two things. And then as far as the 10, sorry, you're doing good, but I'm going to use you. Will you turn around? I'm going to show you the back and I'll also show you the front. So with the front, actually, sorry, watch me for real quick. The front, you're going to start bronchial. So this is where you hear the stridor. So this is one, both sides. Because you may hear it better on one side versus the other. Then when we get to the lungs, we have 2 different lungs. So that's why we listen to both. So 1, go straight down. The second intercostal space. 2, go straight down again. 3, then start following the curvature of the body, right? Then you're going to come to the sides here. That's 4. And then you'd go 5 is mid-axillary line. 1, 2, 3. Does that make sense? Following that pattern. That way the stethoscope's not going crazy. Then when you do the back, you're not going to listen up as high because you won't hear the stridor up here. You're going to listen to it right here on the back. So you have 1, 2, 3, same thing, go down the curvature. 4, 5 on the side. Does that make sense? Now, if someone is old or they're on a lot of oxygen, can they take all those deep breaths? Deep breaths 10 times, there's no way they're going to pass out. So what's the minimum you have to do to fully assess how many lung sounds or spots would you have to go to? How many? 5. I like 5. Why?
What is? I don't know.
Okay, but that's an odd number, but I like the number. Can you guys think why?
Because you have 3 lobes on your right side and 2 on the left.
you do, but it's actually because you still want to know, is the bronchial region having a problem? So that's one, the top and the base. There's only the three on the right side, and a lot of times, unless you know exactly and have been trained, you're not going to know if it was the middle versus the lower lobe. So it's just that you get this bronchial region. So it'll be here, 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 and then on the back, top, bottom. Does that make sense? So that's your critical thinking to decide who you listen to and for how long. Okay, then I'm going to listen to my breath sounds. So I have the bronchial region, I'm listening for Schreider, right? We've talked about this. Vesicular, I'm listening for those, and then you're done with that part. Then I'm checking, I've already checked for oral nasal secretions. I also looked to make sure that nothing was occluded. I would also note if she had any oxygen on. She doesn't, but if she did, because these are the things I want you to know so that in real life you know what to assess. I would check to make sure the modality is where it's supposed to be placed, so that's prongs, it's in her nose. I'm going to make sure that this is turned on to whatever the order was for. Okay? Next, do you have a new cough? A lot of old people cough for all sorts of reasons. I don't want to hear all those reasons. Is it a new cough? Okay. Once you work long enough, you're like, come on, tell me the next story. Let's move on. Okay, then I'm going to check for muscle strength. So if you have very sensitive fingers, people just do, if you'll go like this, it doesn't hurt nearly as bad as if they squeeze it between fingers. So a lot of times I'll go like this. Go and squeeze both sides. Okay? And I'm just seeing if it's equal. What is the plantar flex? Up or down? You're pushing, you're planting something in the ground. So I'm going to have her push against my hands. This is dorsiflexion. Pull up toward your face. Know the difference. I know it's on a test question somewhere. Unless you rewrote the test. While I was down at the toes, this is also where I'd have socks off. I can check cap refill. And I can also check pulses down here. Make sure you know where the pedal pulses are. Okay? It's right off the ridge. Right between those ligaments to the side. So you've got pulses up here. Cap refill. Pulses. Cap refill. Does that make sense? That's where you can throw that one in. Okay, do I want to get someone that's old up and moving right now for a gait? No, because then they have to go to the bathroom, they have to adjust them, they probably want a snack, right? It's going to take too long. And we love them. Trust me, I love people, but it just takes so much time. So say at some point I'm going to have her get up and I'm going to watch her gait and movement. Okay? Then, if she's an orthopedic patient or had a cast, I want to make sure that she has good blood flow and that she's doing okay. So let's say there's a cast from here to here. What is the C part of that? The CMS that we check. Circulation. So how do I check it if it's from here to here? I might be able to get a pedal pulse, but probably not. I would do a cap refill. Okay, the M is movement. Can I have you move your toes for me? Now you've got a huge calf, so she's probably just going to go like this, right?
I forgot.
And then what's the S?
Sensation.
Sensation. So go ahead and look over there. What am I touching? Okay, don't just say, can you feel me touching? Everyone's like, oh yeah, sure. They watch you touch them, and so their brain tells them, yes, you're touching me. So I just say, look over there, what am I touching? Okay? Now, if those were compromised, it's an emergency. The cast is too tight and they're getting what's called compartment syndrome. So we would have to cut the cast off, possibly do a fasciotomy where we cut into the muscle to allow that swelling to happen. So truly, if you find something wrong, you stop. Okay? That's why I want you to know why you're doing certain steps. Okay, go ahead and lay back for me. I'm just going to lay you flat. Abdomen, they always have to be flat. So this is where I would provide privacy. I'd bring this sheet up. I would lift up her gown. We're obviously not doing that because we're students. And I'm just going to assess first. I don't appreciate anything, so I can move on. Then I'm going to listen. In which quadrant first?
Right lower.
Right lower. Vowel sounds for a minute. They should have 15 to 20 gurgles about. Yep, she's sounding great, so I don't need to move on. Your stethoscope would be in, you'd be listening. I really want you to assess and decide. They haven't, okay? I just don't have my stethoscope on me. Then I'm going to say, and this is what it looks like. When you palpate, you're using their finger pads. Any pain here? Any pain here? And don't be up in the ribs. There's no organs there that you're checking. And some people were going like this. Don't do that. That's not palpating. It's literally some firm pressure. Yeah, I don't know what was happening. I'm stop whatever you're doing over there. And then I would say, I'm checking for appendix, right? Gallbladder, stomach, descending colon. Okay? So just remember those things. You can add anything else that are in those categories. Okay, where am I at?
So you check every like organ in that region, or?
You just have to know what organs are in that region and name at least one. Because once again, if you put it in the ninth quadrant, the upper mid is the pancreas. So you just have to know what you're assessing for. So if they have pain, you're like, okay, now I'm thinking maybe you have a gallbladder issue, right? Cholecystectomy because you're in the lymph vein. Not ectomy, that's taken out, but cholecystitis. Okay.
To pass it off, do we have to do each quadrant or just the
So you
one?
would say, right here I'm assessing for appendix, for here I'm doing gallbladder or liver.
Sorry, when you're listening to it.
No, when you're
you just
listening.
have to do the one for to pass it off.
You decide.
Okay.
Bowel sounds are fully intact, I'm done. Or I'm not sure, keep listening. Yep, whatever one works, as long as I know you know what you know.
Okay.
Alright, cool. So next, I'm gonna sit you back up, cover her, alright, gowns down. Okay, so how would you say your diet is? Are you eating 50, 75, 100% of your meals?
Around 50.
Okay, do you get any nausea or vomiting after you're done eating?
Nausea.
Okay, is it after every meal or just some meals?
After every meal.
Okay, so she's being a turd, but no, let's be like, no, I'm doing great. There's actually a lot more questions I want to ask her right now, but that's the idea of if she does that, then I'm going to go down that rabbit hole and ask all those questions. Good job. I'm like, I can keep going to this, but what's that? And then I would say, she doesn't have a feeding tube, but if I did appreciate a feeding tube, I'd make sure it's patent and make sure it's on the right medication, or the right formulas in there, right, and you'd go through some of that. Describe your last bowel movement for me. Was it normal?
Mm-hmm.
If she says, I'm done, because otherwise they want to tell you about every bowel movement they've ever had. And if it's a chronic issue like watery, she's still alive, so she's tolerating it, right? So I'm trying to list any new information. Okay, so the next time she goes to the bathroom because she's being compliant, I could say I would want to see your urine. Can you tell me what your last urine looked like in the toilet?
Clear.
Okay, was it thick at all?
No.
So we need color and is pitch transparency, and did it smell normal?
Doesn't smell anything. So.
Okay, so for her that's normal, right? Every urine stinks, I don't care who you are, your urine smells. That's a bit first, right? It just has a smell, but, or aromatic is the term we use, it's aromatic. But if it's different, then she would know that, right? Otherwise, I could say the next time she gets up, I could assess gait, and I would also assess urine. These are the things I would assess. Does that make sense? That's where you can combine some of that. When you do go to the bathroom, you're fully able to empty your bladder. Perfect. And if she had a catheter, I don't appreciate one, but if she did, I'd make sure there's no kinks. It was hanging on the bed frame, not the bed rail, that it was patent, right? And just go through all those things that it says. Okay, are you having any pain today?
No.
Okay. So you could say, if she was, I'd ask those questions. So I needed a 0 to 10 scale, but I like to put it in the severity part, so I'm not asking it twice or think I have to. So if she was in pain, I would ask her what started the pain, right? And just go through all those questions we've already talked about. Let's see, skin, this whole time I've been assessing her skin, right? Because we would have been checking each thing, so I would have seen a lot of her skin. I may need to turn her over, but I'm looking for color. How do we assess turgor? Where else do we check besides here? Right? I'm assessing right here. And then I'm assessing for edema. I'm going to bring an edema table, but Doran has it right now. I'll get it in just a minute. But we always start down at the feet. So what you do is for 3 seconds, you press down. 1, 2, 3. And then I bring my hand over it to see if there's any. You can, 0 is what you want. You can have a trace up to 4+, and it'll make more sense once you actually see what those look like. But I want to start here because think about blood flow circulation. Everything gravity is going to pull here. But then I have to assess several other areas if she does have edema. And I'm just showing this as a teaching point because you'll see it in the care centers. So if I see it here, the next place I go is on the shin. Press down for 3 seconds. Check. Then you go to right here. Right? The next place is the groin. Shouldn't have it, so I'm not going to assess. But I can just do edema here. If there's not, I'm done. But truly in the care center, you'll see that they have it. You should be assessing, and as soon as you quit filling it, then you're done. But if they have it clear up to their groin, they've either been dependent in that chair a long time, or they really have something wrong with their heart, and they should be looking out for it. Okay? That's just a teaching point to know what edema. Okay, I don't appreciate a wound, but if she did have a wound, I'd remember the taco. Type, amount, color, odor. Is there a drainage system? Is there a dressing in place? How does everything look? Same thing with IV. I don't appreciate an IV, but if I did, I would look to make sure it's patent, make sure the dressing's intact, make sure the fluid is running. The things that I'm watching for with an IV is infiltration, phlebitis. What is infiltration?
Smallness and roundness.
That's phlebitis.
It's when the IV through the vein and goes to the tissue.
Yeah, so the IV was started, probably did it right, maybe you didn't, but it then nicked the vein, and so now the fluid is running outside of it. So warm or cool to the touch?
Cold.
Cold always. Versus phlebitis, remember the itis? And that itis is what?
Swelling.
Inflammation, swelling, and it's always what to the touch?
Warm.
Warm or hot to the touch, always. So that's how you would describe that.
Would phlebitis be like the kind of along the same line of, what's the name of it?
Oh, the infiltration?
The other
The
one.
extra.
Oh, extravasation?
Yeah.
Extravasation is where it's truly been going so long that now that they're probably gonna lose their limb. Like it has
Oh,
just
okay.
been everywhere. It's like all over the
So would you say
tissues.
phlebitis is the start of?
It's usually right where the actual needle went in or the catheter is sitting, and it's just because it's been in there too long or it's been bothered and moved around a ton. Yeah, it's never because the fluid is oozing out in the tissue. Great question. Okay, so this whole time I have been assessing her mood. She's been engaged, not withdrawn, right? Her affect has been appropriate, and so I'm done with my assessment. Stand up. And then at the very end, I'll say one range of motion and you'll perform that. So I'm gonna come back up front. I'll have everyone